Hello, friends. This is Carrie Morrison. After listening to this week's interview on Heartforward Conversations from the Heart, I hope you will be able to connect the dots to make sense of why it is that you see so many people with severe mental illness suffering on our streets. Indeed, this was the actual inquiry that I proposed to the Durfee Foundation when I was awarded a Stanton Fellowship in 2016. Quote, why is it so hard to help the most seriously mentally ill people move from the streets to a safe place to live? For the first year of my fellowship, I looked throughout the country for a better answer, and not finding it in the United States due to the systemic dysfunction that has calcified over time, I found a better way in Trieste, as you know. So today's talk with Professor Alex Barnard from NYU might help you understand why this has become so complicated. He has been studying for the past several years how the conservatorship system works in California. For the layperson listening today, you will better understand some of the concepts you have heard about and how this relates. What does it mean to be a danger to self or others? What is a 5150 72-hour hold? And why are some people released from the emergency room on the same day when they may have truly benefited from 72 hours of care and treatment? What does it mean to be gravely disabled, and why is that such a high bar to convince to the court? In California, we have a severe shortage of psychiatric treatment beds across the entire continuum, from the emergency room to the acute care hospital to residential options. Why might that bed shortage be linked to our homelessness crisis today? This is important information to understand, and you may want to grab a notepad to take notes during this one. Hi, this is Carrie Morrison, and I am so delighted to welcome today to the podcast interview Professor Alex Barnard, who is in New York City right now, and through the powers of Zoom, we're able to have this discussion today. Alex, welcome.
Thank you very much for having me.
Looking forward to someday when I get to meet you in person, when I can go back to New York, my son lives there. I want to be back in the city so much. So we are going to talk today about a kind of a complicated concept, but it is something that is very important and integral to what we see playing out in our mental health system in California, and particularly also in the plight of people who are either homeless or find themselves shuttling in between systems, unsupported with severe mental illness. And that is our system of conservatorship, which we're going to walk through the definitions and be introduced to this concept for those of you who are not familiar. But before we do that, Alex, I would love to know a little bit about you and your origin story, where you were born and how you found your way into this field of study, sociology. I know you studied at Berkeley and at NYU, and that's where you are right now as an assistant professor. So give us a little sense of your origin story and how you wandered into this field of work.
Sure. Well, I grew up in Flagstaff, Arizona. I went to Princeton for my undergraduate degree. And when I went there, I had sort of never heard of sociology in my life, but sort of wandered into a class on poverty and inequality in the US. And it really kind of blew my mind because I grew up in a sort of left-leaning household where we sort of had this idea that, if we were just like Sweden, everything would be fine. And then, we have this other narrative, in the US that's all about kind of personal responsibility. And I think sociology gave such a more complex and complicated picture. And I think that really spoke to me. Initially, my undergraduate research was on something completely unrelated to what I'm studying now. I studied freegan dumpster divers, so people who recover wasted food as an act of political protest, and wrote a book based on that. But reached the end of that and decided I wanted to work on a really different topic, and decided I wanted to work on comparative mental health policy. So where does that come from? I think, it's important to start by saying, there's a lot of mental illness in my family. I think, these are often topics that people don't come to entirely by chance. But from an intellectual point of view, mental health was really interesting to me, partly because my research or my interests are really about understanding social policy and understanding kind of bureaucratic and medical decision making. And there are few people in our society that have as many sort of government figures intervening in their lives as people with severe mental illness. That somebody in San Francisco once told me, we have clients who have 7 social workers. Right. You think of, in the clinic, maybe you have a parole officer, maybe you have a drug counselor, maybe you have someone in your housing. And so if you want to understand sort of how governments intervene in people's lives, I think mental health is a really sort of powerful or interesting site to do that. And then I've always been interested in comparative research because I think in the US, sometimes we get trapped into a really narrow vision of what is possible. And so to me, the advantage of going somewhere else is not necessarily that you see models that you can just instantly transplant from another country to the US, but just that it shows that a lot of what we take for granted doesn't have to be that way. And so that's why I wound up centering my research on comparing the public mental health system in France and the US.
Yeah. So why France? I mean, because, obviously I've spent similar, though not at the depth that you have undertaken, but looking at Italy, and I agree with you completely. It kind of expands your mind as to what's possible. But what was it about France in particular?
Well, some of it is a little bit more haphazard in terms of the personal connections I had to France. But I think there is I'd like to imagine sort of a good sociological justification for the comparison. One is that it's a comparison that's been done a lot in a lot of different domains. And so people have thought a lot about why these systems are comparable or why it makes sense to compare the two. So from pure sociology question, it makes sense in that way. But I think in terms of mental health, what's interesting about France and the US, and I think it's important to say this because, again, we sometimes have this idea that, the problems of the US are really unique to the US and our system can't be compared to anywhere else. But if you looked at France and the US in the 1960s, they would seem really, really similar, right? The vast majority of mental health care was happening in big public warehouse style hospitals. And around the same time, both France and the US decided that they were going to embark on this trajectory of deinstitutionalization, so ramping up community care. But the way it was done was almost sort of in a polar opposite fashion. And so that's why I think the comparison is interesting, because both systems have huge problems, but you can see that those problems are a consequence of decisions that were made 50 years ago and have been reinforced over time. So France let people out of hospitals very, very slowly. It integrated hospitals into the new community care system and created a system that's much more protective, but sometimes to the detriment of promoting people's autonomy. And in the US, the closure of hospitals was much more dramatic. The community care system wound up being completely disconnected from the inpatient care system, which I think is something we're living with the negative consequences of that today. And it's a system that I often describe as it abandoned people into autonomy, which is to say there is a certain amount of autonomy that comes from being left in the street and having generally no one intervening in your life. But is that sort of a real kind of autonomy? Certainly, the people I talk to in France wouldn't see it that way. But that's sort of the kind of different emphasis of the two systems. France really sees people with severe mental illness as people with a chronic illness that requires sort of ongoing and intensive care. And the US sort of has a different vision. That's kind of the foundation of that comparison for me.
And so all of this is going to find its way into a book that you're in the process of writing. I'm sure it's a long project. What's the vision or the scope of this book?
Yeah, so the book is tentatively entitled Mental States, and it's under contract with Columbia University Press. But you're right that academics don't necessarily move super fast. So don't be checking your bookstore anytime soon to see it there. Again, like the central idea of the book is to say, these conditions are roughly similar wherever you are. And schizophrenia has similar characteristics in the US and France. And yet, if you're a person with schizophrenia in these two countries, your life is going to look totally different. And I'm trying to explain why is that? Why in an era where, the diagnostic categories are similar, the medications are similar, the training of psychiatrists is similar. And yet, you see these completely different trajectories that in France, people are staying in hospitals for a long time. They're seeing the same psychiatrist for 30 years, kind of at the same level of care. And in the US, you see people bouncing endlessly between very short hospitalizations, incarcerations, homeless shelters, board-in cares. And so I'm really trying to explain those two trajectories, looking at it both in terms of policy, but also looking at decision-making on the ground. I'm an ethnographer, which means I seek out situations where I can actually watch decisions being made sort of in real time. So in each country, I looked at clinics. So, how decisions were being made about who gets treated in the public mental health system. I looked at courts that were deciding on who is authorized to have involuntary care taken on them. And then I also looked at social service agencies in each country. So, really trying to understand how these policy choices, again, that were made, many decades ago, translate into practice, and those practices, how that leads to just these very different outcomes between the two countries.
That's fascinating. So we can't wait when you're finally on your book tour and we're out of COVID. We'll have a bunch of people coming together for wine and cheese to regale in the celebration of this book eventually.
I really hope we're out of COVID by then.
So let's then move to California. As part of your research, you decided to look in particular at California's system of involuntary hospitalization and conservatorship. And of all the states in the union you could have looked at, what led you to California?
Well, I was doing my PhD at UC Berkeley, so there was a certain natural reason to do California. And I think if you're at UC Berkeley, you really see the consequences of our mental health system right there. My department was right next to Telegraph Avenue. And if you want to see what the outcomes of California's mental health care system are, you can walk down Telegraph Avenue and see people who are, really suffering, and a society, a very wealthy place that has a lot of social services and yet is not managing to meet those people's needs and engage them. So I think California was a natural site to look at in that sense. But I also think California really is it has for a long time been a kind of a leader in transforming America's mental health system. It was one of the first to really undertake deinstitutionalization. It did it very, very aggressively. And then I think today, California is really at the forefront of a very kind of an opposite debate, which is about to what extent should we move back towards a system that has more long-term inpatient care? To what extent should we take a system that is supposedly really focused on voluntary care and move it back to one that takes that protective, we're going to do what's in the best interest of the person, even if it's not what they want kind of approach. So I think, how California manages to deal with the contradictions that everyone in California can see out on the street, I think that's going to be really important in terms of, the whole country, where we're going in terms of mental health care.
Well, I'm grateful that you have turned your sights on California because your work is really important. And it's so many people who have already read your research and had a chance to listen to you are feeling that their eyes are opened to the fragmentation that, as you say, contributes to people's suffering, which you outline in this report, which, by the way, we'll connect to that in the episode notes for this interview. So let's kind of start with some basic definitions. The concept of conservatorship, can you describe what that is? Maybe describe the legislation that created that in the 60s, the Lanterman-Petra-Short Act. Sometimes people will talk about LPS conservatorships. And then the notion of what is an involuntary hold. People will talk about 5150s. These are in our jargon. But just for the people listening so that they have a little vocabulary, walk us through what a conservatorship is.
Sure. So a conservatorship, in most states, and probably the more familiar term is a legal guardianship. And all of a sudden, it's very funny for me to go on Twitter and see that conservatorship is trending. And of course, that is thanks to Britney Spears and then this film, I Care a Lot. So there is actually, this sudden discovery that conservatorship or legal guardianship is an important tool that affects over 1 million Americans. But in California, the system is divided between two types of conservatorship. And again, like the coverage of Britney Spears sometimes doesn't make this distinction. And I think it's important to know. So there are probate conservatorships, which are generally for people who have impaired decision-making capacity as a result of some sort of cognitive disability or dementia, developmental disabilities, things like that. And that's often used to control somebody's medical decision-making and also to control their finances. What that kind of conservatorship does not allow you to do is to put somebody in a locked facility or to require them to take psychiatric medication. And that kind of conservatorship, again, called like an LPS conservatorship, was created in 1967 through this very famous piece of legislation, really, kind of known not just around the US, but around the world as very dramatic shift in models of how to deal with severe mental illness. And so what the LPS Act did is it took a system where it was quite easy to put people into a hospital and leave them there for long periods of time with very few legal protections. And it created a system where it is actually very, very complex and takes a lot of steps to put somebody in a hospital and to keep them there. And as a result, at the time, the LPS Act was hailed as the Magna Carta for the mentally ill, or a Bill of Rights. I've been looking at newspaper clippings from back then, and they really talked about it as a mental health revolution that was really bringing mental health care out of the dark ages. And I do think because now there's discussion of kind of repealing or revisiting LPS, it's important to remember just how horrible and abusive the system was beforehand and why it was so important to create these legal protections. So getting onto an LPS conservatorship, like I said, it's a lot of different steps. I guess to just be clear about the definition, sort of the end of that, an LPS conservatorship is where somebody is appointed by a court. It could be either a county official or sometimes a family member. And that person sort of becomes the legal guardian of the conserved person and assumes some really, serious powers over that person. So they control their money, they control where they live. Again, that could include having a person live in a locked facility, and they can consent to, psychiatric treatment on a person's behalf, which is to say, a person could be treated with medication against their will. Conservatorships are granted by the courts for a 1-year period, and then they can be renewed yearly. So I call it conservatorship continuum to say there's a bunch of steps that lead to a conservatorship, and they sort of all have to line up for somebody to be conserved. And if you drop off the continuum at any of those places, you have to start over. You kind of have to go back to the beginning. So the first step for the majority of people who are going to be conserved is that they have to be placed on a 5150 hold. So this is another thing that was created by the Lanterman-Petra Short Act, and it's a 72-hour, it allows a peace officer or clinician to obligate somebody to have 72 hours of evaluation in an inpatient unit. And it can be done based on somebody being deemed a danger to themselves. So usually that means, potentially suicidal, a danger to others. That could include, threatening or some sort of assaultive behavior, or gravely disabled. And gravely disabled means that as a result of somebody's mental illness, they're not able to provide their basic need for food, clothing, and shelter. So that's where this continuum starts. And the state doesn't have great data on this. We know that over 100,000 5150s are done per year in California. So this is not something that is super uncommon.
So let's talk about what happens sometimes with the 5150. And this might actually relate to the larger discussion about the capacity of our medical system to actually handle and receive people who are in need of the 72 hours treatment, or perhaps longer treatment, which would be a 5250, which you might want to describe as well. Having managed the business improvement district in Hollywood, where we would see sometimes somebody had been picked up on a 5150 and taken to the emergency room, we would see them later in the day, still with their hospital bracelet on. They had been released. So in this continuum that you're describing, the continuum of restraint, the various steps, something can happen at the emergency room level where perhaps there's not the capacity, not the beds. Talk a little bit about the system capacity to actually accept and treat people who might be in need of this care.
Yeah, so again, we don't have really clear numbers, but we know that it's a pretty small proportion of people who go to psychiatric emergency rooms who are actually admitted to a hospital. And remember, for somebody to be 5150'd, someone has to believe this person is in danger or dangerous to others or really sort of not making it in the community. And that's part of why it's so surprising that you see somebody 5150'd and they're back on the street a few hours later. And I think that creates, huge amount of frustration for law enforcement, for outpatient clinicians, and for families that they work very hard to get somebody to the hospital and then they're back. Maybe they've gotten a day's worth of medication or something, but they're kind of back where they started. Like you said, the easy explanation is just that there aren't that many inpatient beds in California. So for an ER clinician, there's sometimes nowhere to put someone. There's no room at the inn. So California's lost 40% of its acute inpatient beds since 1995. The state has, relative to the population, it has fewer beds than kind of almost any European country. It's below the national average. So there's nowhere for people to go. And so naturally, ER clinicians are not going to admit people if there's nowhere to put them. There's other things that sort of play against conservatees in the ER as well. So ERs are very crowded places. They have limited resources. They have limited clinical time. And what I learned from interviewing ER clinicians is that they're really focused. The person who's going to get the most attention is the person who is disruptive, who's calling a lot of attention to themselves. Whereas somebody who is just, kind of gravely disabled in the sense they're just not able to sort of survive, they're not taking care of themselves, that's not going to be the person where the resources go. So that's not going to be, what attracts the most attention. There's also a lot of questions in California right now about what to do with people whose behavior seems to be a result of substance use. So, somebody who's using meth, some of their behaviors could seem very similar to somebody who's dealing with psychotic symptoms of something like schizophrenia. But there's a perception that, well, if you put that person into the hospital, they're going to stop using meth. And so they're going to sort of normalize really quickly. And then you're going to have to release them. So why even bother admitting them, especially if we don't have good substance abuse treatment anyway? So maybe somebody who has co-occurring mental illness and, drug use is nonetheless not going to make it through an ER. And then I think sort of third factor that's playing into this. So there's a capacity issue. There's a defining what is paying more attention to people who are disruptive, releasing people with drug use. And I think there's a third issue, which is, again, a sense of futility among a lot of clinicians, which is to say, I'm going to admit this person and what's going to come of it, right? Like, are we actually going to be able to do any good for this person? And there's this idea in a lot of ERs of the frequent flyer. So it's the person who just keeps coming back over and over again. Their problems are often as much social as medical. They need housing, they need a place to sleep, they need food. And an ER isn't equipped to provide that. And they know that a hospital isn't really going to fix that for the person. So that person too, even if they're very, very sick, might nonetheless not get through an ER. And so again, they would drop off the continuum.
Yeah, after having visited Trieste now 5 times, this is something that would not be utilized except in the rarest cases in that city. And it's because they don't allow people to get as sick and they don't abandon people the way we do in the United States. So people will sometimes counter me like, why are you such a fan of what you've seen operating in Trieste, yet you are actually in favor of involuntary hospitalization for people on the streets? And it's basically because we've seen people die on the streets. So in a sense, in the American system, because we don't have that sustained community care that can avoid this kind of downward spiral, it is seen as a way to save someone's life to actually have them hospitalized. So that's just my editorial comment right now, because I know I will get challenged on that. Let's walk through ideally. So let's say, you've got someone who is gravely disabled, who is very sick, and they get past the emergency room. What happens next on that stepping stone continuum to ultimately get to a judge awarding the 1-year conservatorship?
Sure. So there's still a bunch of intermediary steps. And I do think, we have to keep in mind that what one policymaker might think is the system dysfunctioning, someone else might think is functioning perfectly well, which is to say there's a bunch of steps. There's a lot of opportunities for people to fall off the continuum. And if you think that conservatorship is a sort of horrible abuse of people's civil rights, that's the way it should be. But I think, and hopefully I can articulate that a lot of people are being pushed out of this system for reasons that are really not about their best interest or their rights. So if somebody's admitted to a hospital on this 72-hour hold, after 72 hours, they either have to be released or they have to be put on a 5250. So that's a 14-day hospitalization based on the same criteria, which is danger to self, danger to others, or grave disability. And that after 5 days has to be reviewed by a hearing officer. So there's a, kind of a short hearing in the hospital. The patient is represented by a patient's rights advocate. And so at that point, the hearing officer could release the person. The person can also apply to see a judge. They can file a writ of habeas corpus. They'd be, represented at that point by a public defender. So there's a lot of legal recourse for people during that 14-day 5250. But really, as far as I can tell from my research, the real thing that plays into this is financial considerations, which is to say, for hospitals, these involuntary patients can be very expensive, and insurance reimbursement, particularly from public insurance, so Medicaid, which is what a lot of people with severe mental illness, because they are economically precarious, it's the coverage for a lot of those people. The reimbursement rates for Medicaid are not that high. And there's all sorts of pressure coming from insurance companies to discharge people quickly. So as far as I can tell, that's really the number one reason that the vast majority of people on 5250s are being discharged very quickly and sort of not continuing on to the conservatorship system. But so say somebody is actually still danger to self, danger to others, or gravely disabled after 17 days. At that point, the hospital can apply for a temporary conservatorship. So that's a 30-day hold. And it can only be based on grave disability. So remember, we have these 3 criteria, and all of a sudden it narrows to 1. Again, at this point, it means that the person has been medicated, they've been on an inpatient unit for 2 weeks, and yet we still don't think that person is at a level where they could manage to get food, keep themselves clothed and have some minimal shelter. And we're really talking like pitch a tent level. That's what counts for shelter in so many cases in California right now. So that person is still gravely disabled. So you can apply for a 30-day temporary conservatorship. And at that point, there's a whole new agency that becomes involved, which is the public guardian's office. So each county in California has a special agency that handles conservatorships. And that public guardian's office is going to conduct an investigation to see if conservatorship is appropriate for that person. So they have to confirm that a person really has a mental illness, that it's not just drug use, that it's not something like dementia, that it's not a developmental disability. And again, they're also going to confirm that there's no other way for this person to sort of survive on the street. And again, like often if the person says, look, I've got a disability check, I know how to get to the food bank, I have a tent, sometimes that's going to be sufficient. That's going to count for what some people I interviewed call successful homelessness, right? You're making it, you're not sort of bothering the neighbors too much, and we don't think you're going to die. We don't think you're at imminent risk of death, and you say you don't want to be in the hospital and you don't want to be conserved. So we're going to accept that. At this point, so the hospital has applied, the public guardian has done an investigation, and say the public guardian has determined this person is really not a successful homeless person. This person is not going to make it on their own. Then there's a court hearing to decide if the person is going to go on to a permanent conservatorship. And it's a totally misleading way of describing it. It's a 1-year conservatorship. And in that hearing, sort of the same questions are going to come up. So is this person, can they articulate some sort of plan for how they're going to make it without conservatorship? And if they can't, the judge might rule to put them onto conservatorship. But it's a very high standard. It's like a criminal case. The person can ask for a jury trial. Psychiatrist who's testifying has to prove that the person is gravely disabled beyond a reasonable doubt. And so if you meet that very high bar, then the person is sort of officially under permanent conservatorship. And that means that either the public guardian or a family member takes on these powers of a conservator, which is, again, controlling somebody's resources, consenting to treatment on their behalf, psychiatric treatment, and deciding where that person, having the legal capacity to place that person in a facility, including a locked facility.
So as an ethnographer, is that the word? I suspect you probably sat in on some of these conservatorship hearings. I'm curious to hear and read that families of adult children with serious mental illness who really worry about their children out on the street, suffering on the street, in danger of some mishap or dying, would certainly would want the court to grant a conservatorship. Are family members or friends or others able to testify in this hearing to the judge?
They are able to testify, and sometimes that happens. But, in a lot of cases, the people who are coming up for conservatorship are people who have often, through no fault of their own, but have burned a lot of bridges, right? That they have been living with their family, or their family has tried to help them in various ways, and that hasn't worked out. And maybe that person, and a lot of people, with severe mental illness are pretty disconnected. They don't have a lot of family or people close to them. So families can testify at any point. If a family steps up and says, actually, we will take this person in, at that point, the county is going to say, well, we're not going to conserve this person, right? The public system is not going to take care of someone who has some sort of private support like that. So families can testify. But again, the standard here is really, really high. And as many judges have told me, it's not about, has this person failed in the past? It's really about, is this person gravely disabled right now? And so I think it's a huge frustration for families that they could be communicating with the inpatient clinician or the public guardian or the, testifying before the judge and saying, look, we've been on this merry-go-round many times. I hear about people who have been hospitalized 100 times. And they can say, every time my family member says, yeah, I know how to take care of myself. I'm going to go live in this place. I know how to get food. I have a Social Security income. Every time they say that, and then they stop taking their medication and they fall apart and everything starts over again. But, that's really not what the judges are supposed to be deciding based on. They're not supposed to be looking, the fact that somebody has failed in the past is not really the centerpiece of these trials. It's really, what does this person look like today? And I actually think that's a big challenge or problem in the system, is that it's a system that repeats the same thing over and over and over again, expecting a different result through no fault of the professionals working in it, but really as a result of the way, these hearings and these decisions are set up to just focus on what does this person look like today or this week.
Yeah. What I love so much about your research, Alex, is that you put language to things that we are noticing but didn't quite know how to articulate. So you make the distinction in your report about a people changing bureaucracy versus a people processing bureaucracy. So a people processing bureaucracy is like the Department of Motor Vehicles, where we get our driver's license. But a people changing bureaucracy arguably could and should be a mental health system that is looking to focus on a person's recovery and can sustain treatment. And in everything you've described right now, which is enormously complicated, the focus seems to be less on what's good for the person in their life transformation and their recovery, and more about how are we going to get through these steps. So, well, your report is called Absent Authority. Maybe define absent authority as you have seen this operating in our system of conservatorship. And then the notion of street level bureaucrats, which I loved, the devolving to the lowest possible level, really important decisions about human beings. Walk us through a couple of those concepts.
Okay, yeah. So that's a little bit sociology terminology soup. So I'll try and define them, but also explain why I think some of these concepts are useful. So I've been describing the conservatorship continuum as in a state of absent authority. And so the authority part is the idea that, conservatorship is a really powerful tool. The ACLU says conservatorship is the greatest deprivation of civil liberties aside from the death penalty. And that might seem exaggerated, but a person who is conserved under LPS, they can be put in a locked facility that to them might feel like incarceration. And they can have their bodily integrity violated by, being forced to take powerful medication that they don't want. And all of this, though, is being done in the name of people who might die if you don't do that, right? So the stakes of conservatorship are really high. And this tool is really powerful. And yet there's this tool, but it's not actually clear who is supposed to use it or who has responsibility for using it. So you could say, well, there's this office called the public guardian in every county. So maybe the public guardian has the authority to use this tool. But actually, the public guardian can't make the ER clinician admit a person. They can't make the hospital decide, even though this is really costly, we're going to keep the person. The public guardian can't decide on behalf of the judge. And so there's actually no one to coordinate this whole continuum of all sorts of different actors, police officers, clinicians, judges, lawyers. There's sort of no one standing above that trying to make those actors work together. And so that's what I'm thinking of in terms of absent authority, that it's this powerful tool, but that no one really has the information, the resources, or the kind of coordinating power to use effectively. Street level bureaucrats is a way that sociologists have thought about social policy. And the idea of it is that, we think that policy is made by a legislature passing a law, but really policy is made from the ground up by the everyday decisions of bureaucrats. And we have such a pejorative view of bureaucrats, but sort of, all public servants are acting as street level bureaucrats, whether it's a doctor or a clinician, a judge, which is to say, they usually have a fair amount of decision-making autonomy. And that autonomy comes from the fact that public agencies almost always have more people they could serve than they have resources to serve. And so they're exercising discretion to decide, with my limited resources, who is going to get, whatever service I'm providing. And so, the issue in the conservatorship continuum is you have all of these under-resourced agencies that are scrambling to do the best with whatever resources they have. But those, decisions don't always line up. So at one point in the continuum, the ER clinician may say, well, we don't have enough space, so let's give our beds to the people who are really dangerous and disruptive. But then 2 weeks later, you have an investigation by a public guardian who says, we're not here to, conserve people just because they're dangerous. We're here to conserve people who are gravely disabled. And so you have two bureaucracies that are sort of doing their best, but they're doing their best in a way that isn't coordinated. And that's why, this absent authority is an issue, that there's no one who can make those two agencies work together in the best interests of the person.
Is there a countervailing institution or system what would be the opposite of absent authority or coordinated authority? And if whatever that is from a sociological perspective, is there an example of a system that we can get our minds around as to what the potential might be if we could integrate this better?
Sure. So maybe I like alliteration. So let's stick with maybe the opposite of absent authority is accountable authority. It's where the power is being exercised, but we know who's exercising it and we can call them to account, right? Like we as a public or as citizens can regulate it. We can demand data about it. We can evaluate it. I think that it's worth bringing in the French system because I spent a year and a half there and learned a lot about it. And it's absolutely not a perfect system at all, but it has a certain kind of accountability because a lot of things that are very fragmented in the US are very integrated in France. So in the 1960s, they divided the country up into what they called sectors. And a sector is just a unit of 70,000 people. So everyone in France is in one sector or another. And each sector has a public psychiatric team assigned to it. So what is that team? That team is psychiatrists, nurses, social workers, psychologists, all working in one organization. They have, maybe a clinic, a day hospital, some apartments, and some beds in a hospital. So there's not a hospital in every sector, but there's some beds in a hospital that are assigned to that sector. The point of that is that, somebody in that system, first of all, it's really clear who's responsible for them. So if you ask for psychiatric care and you live in the sector, that sector has to say yes. It doesn't matter how many people they have. It doesn't matter how overworked they are. Like, you're their responsibility. And in that sector, if you get hospitalized, the doctor you have in the hospital is either the same doctor or works next to the doctor you're going to have on outpatient. And so there's much more coordination, and there's very little of what we might call burden shuffling. So burden shuffling is an idea we have with street level bureaucrats that are, these overworked, under-resourced bureaucrats. They're going to push off the clients that they see for whatever reason that they don't want, because they're, people that are really hard to treat, because they're people that are expensive to treat. It's people that don't want their services. So, for example, a lot of people in our system burden shuffle people they perceive as addicts, right? They don't want to treat substance abuse. In France, there's very little space for that, because if you're an inpatient clinician and you say, I want to discharge this person really fast, well, that person is still going to be your problem when they leave. They're going to be directly your problem because you're still their doctor, or it's going to be your colleague's issue. And so the incentives are really different, because if that's the case, you really want to keep that person in the hospital long enough for them to stabilize. And so that's kind of what I'm thinking about in terms of accountable authority, where if somebody, a resident of a sector, we know who's supposed to be meeting that person's need for mental health care. There's sort of no question about that. And that person, that psychiatric team, they can't sort of get out of that, right? Even if it's a client that's really, really difficult. And that, they don't necessarily like serving that person always, but they know that it's their job. They're a public service and they have to accept everything. So I think that level of integration is what's really lacking in the US.
Yeah, the system fragmentation is what people fall through the cracks over and over again. And I saw that in Italy as well, the accountability factor. Do you think that this is tied to our way of funding medical and psychiatric services? Certainly there's more national level healthcare in Europe. Is it a function of just how fragmented our medical and psychiatric healthcare systems are funded in the United States?
I think this is always the challenge of can you compare the US to anywhere else, given that everywhere else has universal health care? And I do think we can make that comparison, because the mental health system in the US has often been set up and funded on very different principles from the rest of the medical system. So it's not like just because our medical system is different from France's that it's impossible to imagine that our mental health system could be set up in a similar way. And even within France, we talk about, France has a universal healthcare system. But, in the 60s, they realized that the mental health system needs to be sort of even more universal than the rest of the system. So in a lot of places in France, yes, you have insurance, but you might have a copay, or you might have to pay up front and be reimbursed after. The public mental health system is free at the point of service, right? It's just no money is changing hands. And that's based on the idea that there's an expectation that people with severe mental illness might be impoverished, and that you don't want to have any barriers to treating them. So I do think, part of the story is about, just the US medical system in general is harder to access. But I do think, there's no reason necessarily that the US couldn't in the 1960s have decided to have a greater level of integration between hospitals and community clinics. There were people who were advocating for that. And then there were people who said, no, we really don't need hospitals. State hospitals are awful, can take care of everything in the community. So, decisions were made, and those decisions are really hard to reverse. But it certainly doesn't have to be that way. The US doesn't have to become France to have a very different mental health system.
In the time that you've been doing this research, which I think started in 2018, what was surprising to you that you discovered that you perhaps did not anticipate?
I'll say two things. One is really simple. It's just that there's just very little research out there about conservatorship. Research, whether it's from academics or sort of public reports that have been written or databases or something. Like I said, before this, I studied dumpster divers, and there is more academic literature on dumpster divers than there is on conservatorship. Now, I'm not exaggerating. Sort of the last serious surveys we had to understand who is on conservatorship in the state were done in the late 1980s. That's what I can find. There's one study from 2009 on conservatorship hearings. But so I was really blown away by how little we know about this. And in some ways, what I'm doing with my research is more trying to identify what we don't know more than being able to really answer a lot of those questions. I think the second thing that I only realized really in the course of this research is one of the reasons this whole situation in California is so complicated is precisely that we are trying to run public safety net services through a lot of private actors. And there's state hospitals were very public and they were also really awful in the 1960s, right? So it's not like you say to the public sector, you should do this and everything gets better. But I do think in California, the conservatorship system is supposed to protect people who are at risk of dying. And yet that system depends on market forces and profit interests. The number of beds in California really depends on, these reimbursements from private insurance companies. People are being released as a result of the practices of managed care companies. A lot of these locked facilities are private and for profit. So they have an interest in taking certain kind of cases and not taking other kind of cases. And so I think one of the things that really needs to be reflected on, especially as people are talking about, well, we need more beds. I think we need to think about what kind of beds and what is the right role for the private and the public sector. But at the same time, a lot of people I talk to, they're really excited about some of these private providers, places like Synergy or Everwell Health. So, I'm not sitting here saying there's no role for the private sector. It's just that public safety net services need to be thought of as an entitlement. It just can't rely on, the goodwill of these really hardworking founders of some of these companies that are taking on millions of dollars of debt. That's just not how you create a safety net. That's not how any European country is creating a safety net.
Well said. Before we kind of move into discussing a few of your recommendations, you obviously interviewed hundreds of people. And I love the way in your report you intersperse the actual narrative, quoting people working in the hospitals, ERs, people, law enforcement, families, etc. Is there any particular story or scenario that kind of still haunts you as emblematic of why this system needs to change? Or maybe a story that kind of inspires you where the system worked and the transformation that a person experienced was healthy in the long run? Just share one story.
Well, you gave, can I do two since you
Sure.
give a negative? So, and I should say that I'm still conducting interviews and there are really gaps in my knowledge, but sort of one of the groups I've talked to a little more in the last few months is family members. And I remember talking about to one woman who spoke about her son who was very deeply paranoid and essentially stopped eating. And she called the police multiple times and they would come out to do an evaluation. Her son would just hide and he wouldn't talk to them. And the police would say, well, we can't beat down his door. And there's good reasons why we don't want police beating down doors anytime, you call them for mental health evaluation. But in any case, her son is basically starving and the police are coming in and they're just saying, we can't help you. We can't help you. And then eventually she kind of lucked out. She said she got kind of an older, more experienced officer who maybe had a bit more of that paternalistic French instinct, perhaps. But, and he looked at it. She showed him his driver's license and showed him her son who's lying on the couch and who's just emaciated. And he said, okay, I can see he's gravely disabled. But he had lost something like 80 or 100 pounds by that point. So that's what it took. And if I recall, he went into the hospital and he was back out in 2 weeks and stopped taking his medication. And so imagine all of this for this, right? Like that's the end point of that. I think at the other end of this, there just are so many professionals in the system who are working so hard and working and just the issue is the system, right? There's just so much good intention and so many great professionals. And it's been really interesting to talk to conservators. Some of the smaller counties, they have a really small number of conservatees. And so the public guardians get to know them really well. And so, I can't think of a precise story, but, I heard about, I can think of one where a conservator, she recounted, they had a conservatee who was just, very, very paranoid and very skeptical and had a lot of traumatic interactions with the mental health system. And, at some point, I guess they threw this conservatee a birthday party and the conservatee, gave their conservator a hug. And it was kind of if you imagine like the conservator is this person who is, taking your rights away and is forcing you to take medication, but this like sort of moment of acknowledgement of sort of mutual humanity. I think those are the kind of stories that I think, sort of keep you going and prevent you from getting too desperately sad when you're researching this.
Yeah, it is sad, but you're doing such important work to shine a light on it. So your study at the end lays out, I think, 8 different recommendations that I know you're out trying to share this information with policymakers and folks who would be advocates. We can't go through all 8. And of course, people can read this in the report that I'll attach. But, maybe 2 or 3 that you would want to share that you feel are most compelling and are things that all of us should be thinking about, learning more about, and can maybe help make a difference.
Sure. I think in some ways it's, such a general recommendation and seems almost absurd, but I think we have to sort of keep our eye on the prize, which is that we're asking the mental health system to do way too much in the US. And we're asking it to clean up for a system that doesn't provide education, doesn't provide housing, doesn't provide dignified welfare payments, doesn't provide enough disability income, is racked by mass incarceration and racial injustice. And so I think we kind of need to start from the perspective that, our goal should be that the mental health system just has much less to deal with because it's a society with less trauma and poverty. But I realize that's very, very far from what any of us feel like we can act on right now. I think that, the state needs to take a more direct role in overseeing our conservatorship system and supporting the conservatorship system. That we don't have the most basic data we need to create accountability and to evaluate the system. We don't know what the outcomes of conservatees are and who it's working for and who it's not. And there's a huge amount of variation between counties. And California's a huge state and the counties are really different. So, what works in Trinity County might not be what works in Los Angeles County, given the difference in size, several orders of magnitude, I guess. But nonetheless, it's not fair to conservatees that, in some counties, the services you're going to get are so radically different from another. And even the powers that conservators will exercise over you are so different. So I think, sort of stepping up in terms of having greater leadership in terms of creating evaluation and accountability and standards for the system, I think is really, really important. I think, all around the state, you hear this desperate call for more placements. More places for conservatees to go. And, it's interesting because like you said, there are models like Italy that have way fewer placements than we have that, have barely any locked facilities. But it's true that if you look comparatively, California has a lot fewer hospital beds than a lot of countries. It has, a quarter as many relative to the population as France does. And so, I believe that we probably need more high-level care for people. So something more than just an outpatient clinic for some people, at least temporarily. But I think that as we talk about it, again, we have to keep our eye on the idea that just because something is a hospital or very intense doesn't have to mean that it's involuntary, right? Like a lot of people go to hospitals for a lot of conditions voluntarily. But unfortunately, we've created a system where there's so few hospital beds that we wait to the point where people are doing so badly that they can't consent. And then we push people out so fast that why would people want to consent? It's not going to solve their problems if they're going to get medication and get kicked out after a few days. And so I think if we created more resources for those higher levels of intense care, I think people would want them more, and it would give clinicians in them sort of more space to do their work and to build relationships with people. So I support this demand for more resources kind of on the more intense end of the spectrum. But I think we have to remember that maybe if we had more placements, we could use them differently and use them in a more voluntary way. I think the last piece is I think we need to empower the public parts of the continuum, which is to say the public guardians and the judges and the public defenders as the people who are really, especially the public guardian, as a group of people who are really accountable and have the resources and capacity to coordinate this continuum, right? That right now it takes this sort of aligning of the stars to get onto conservatorship, because you have to, like I said, somehow a police officer, an ER clinician, an inpatient doctor, a judge, they all have to agree based on, somebody on really fluctuating condition. Somehow they have to, every day when they go in front of these people, they have to look gravely disabled. And I think, having better resource public guardians who can more proactively identify people in the public mental health system who could benefit from conservatorship, I think that could be really useful. But currently the caseloads of the public guardians and their funding doesn't make that possible at all.
Those are great suggestions and so important and so clearly articulated. Alex, you said that this is still a work in progress and that you are still doing research. So for those who may be listening and who either have stories to share or would like to contact you in some way, are you open to that? And what's the best way for people to be in connection with you?
Sure. So, anyone can email me at avbarnard, avbarnard at nyu.edu. I'm interested in talking to as wide a range of stakeholders as possible. Right now, I'm focusing on some groups I feel I haven't sort of gotten their perspective as much as I would like, which is law enforcement, people working in county mental health departments, and going forward, conservatees themselves. And I think those are the voices that are the most absent. I'm in New York. It's not an easy time to do some of this research, but those are anyone with a stake in the system. I'm interested in speaking to them, but those are the groups that I really feel I've not sort of heard their voices enough yet. I don't use people's names and I don't identify counties. That's kind of a standard sociological practice. It's a little maybe different from journalists who want people to go on the record. We really say, a lot of what we do is off the record. And I want to say, this is work in progress. And in some ways, the people I'd be most excited to hear from are the people who think I'm wrong, the people who have a counter story, because I am just trying to get the whole spectrum of opinions and experiences. And it's a huge state, 58 counties. And as a result, it's really hard to make generalizations.
So like you say, there's just been a dearth of research and information on this topic. And I think you have done a tremendous service. I remember when you first sent me a draft of this, 5 or 6 months ago, I took my breath away that you were actually encapsulating in your writing and in your reporting things that we had seen played out on the streets of Hollywood, in my view, particularly observing people with chronically homeless, seriously mentally ill, suffering. And you have really helped to create language for all of us who care about this issue, families and policymakers, people in the system. And we're grateful that you chose California to study. And I'm so, so grateful that you agreed to be interviewed today. And I know that this is an interview that's going to be of great interest to folks who listen to this particular podcast. So thank you, Alex. I look forward to meeting you one of these days.
Yes, absolutely. Well, thank you so much for inviting me. It's an honor to be here. I feel, given your other interviewees, I'm a little bit standing on the shoulders of giants, but I hope I can add something that's interesting to the listeners and sort of contribute to. I talk to a lot of people with really different opinions, but sort of the shared commitment to a better mental health system, I hear sort of up and down the system. So
yeah, we all believe in that. Thank you, Alex. Have a lovely day.
You too. Thank you.
I think listening today, you can see the link between how it is that people are relegated to living on the streets, or worse, end up in jail or prison because of the failure of our system to provide sustained, effective, and community-based mental health care. I know that so many of my listeners are always looking for the call to action. So many important questions were raised in this interview, and they will be amplified in Professor Barnard's excellent report, which is available in the episode notes. When you are engaging policymakers on our crisis of homelessness, you will now have more language and data to speak up and push back that housing first is the end-all and be-all answer to homelessness. For people who are in need of treatment and recovery, housing may be in their future, but first they need care. Next week, we are going to travel across the pond to talk with a young psychologist who was raised and educated in Trieste, but now lives in London. This will be a fascinating look into the contrast between the Trieste system and the national health system in the UK. Vincenzo Pesante will also help us do a deeper dive into the writings and vision of Dr. Franco Basaglia. A huge benefit for me, since so many of his important writings have never been translated into English, and Vincenzo will translate those concepts for us. This podcast is a collaboration with Peer Mental Health, and I am indebted to having at my side, virtually that is, Paul Robinson, who is so ably provides the technical support to make this podcast possible. I will see you next week.